We are hearing loud and clear. Okay, so can I start my webinar right now? Okay, so I'm gonna repeat what I said all over again. First of all, I would like to thank Dr. Abhishek Banerjee, founder of Frey of Hope and Care Foundation in India, for inviting me over to your Facebook page to give a webinar on facial aesthetics. I am Dr. Noury Adel. I'm an oral and maxillofacial surgery specialist from Cairo, Egypt. I'm working as an assistant lecturer in the Department of Oral and Maxillofacial Surgery at Misr University for Science and Technology. And I'm also the owner and founder of Cosmetico Facial and Dental Beauty. Okay, we can hear you well, sir. Okay, so since I have been told by Dr. Abhishek that most of the members are from dental background, so first of all, why would a dentist seek to practice a facial aesthetics? Actually, for a lot of reasons. The first of all, I don't know about your dental schools, but as far as mine in my own country, our first encounter with a patient was by giving a dental nerve block or a dental infiltration. So we don't fear the use of needles. Able to use needles in doing and syringes in doing Botox and filler with any sort of discomfort for you. Second, we all have studied head and neck anatomy, so we are very familiar with the muscles and the arteries and veins and nerves in the head and neck area. Also, when as a dentist, whenever you get to do an orthodontic appliance, or you get to do a Hollywood smile or any digital dentistry, you are always familiar with the concept of the golden ratio and the normal facial proportions. You know the rule of thirds and the rule of fifth. We know the length of the nose should be equal to this distance. We also know that the line that's connecting the medial canthus to the medial canthus should be equal to the interalar distance. We know that the mid-pupillary line should be parallel to the occlusal plane and the intercommissural width line. So as a dentist, you are fully familiar with the ideal facial proportions. So all those factors makes you as a dentist qualified to do facial aesthetics. You are not less than a dermatologist or a plastic surgeon. Actually, they should be the ones who have a dental background. Good evening, sir. Good evening to everyone. Thank you. So let's get into our topic. First, we are going to talk about neurotoxins and dermal fillers in the facial area, especially in the perioral area, since most of the members are dentists. So this is actually the point, the area that you should be a concern of yours. What is a neurotoxin? A neurotoxin, it is a protein that works on the cholinergic nerve endings. It works by preventing the acetylcholine vesicles release into the synapse, thus inhibiting the action in this area of the nerves. So if this area is a neuromuscular junction and you blocked the acetylcholine release in this area, then you are going to have a muscle paralysis or a muscle relaxation. If this area is a post-ganglionic cholinergic, parasympathetic or sympathetic nerve vipers, then either you are going to have a decrease in salivary secretion or decrease in sweat secretion. So from this mechanism of action, we can conclude 3 points. That first, the neurotoxin proteins act on the muscles to prevent its contraction or to minimize its contraction. Second, it works on areas with high salivary secretion, such as the parotid gland or submandibular gland, by lowering the salivary secretions of those glands. It works in areas where there is an excessive sweat secretion, such as the arms, the underarms, the sole of the feet. When it works in those areas, it decreases actually the sweat secretion. So we now know that neurotoxic protein are proteins that work on cholinergic nerve endings by inhibiting the acetylcholine vesicles release, and it works on 3 areas, whether a sweat gland, salivary gland, or a muscle. Now, the word neurotoxic protein, it is a scientific name, but when we get to deal with neurotoxic protein in the market and we want to buy a neurotoxic protein, we have a lot of brands in the market. We have Botox from Allergan, we have Dysport, and we have Xeomin, we have Neuronox. All those are types of neurotoxic proteins that are present in the market. They are actually all powder form. I do have a vial here. I cannot see if you can see it well or not. This is a vial of a neurotoxic protein, a brand called Neuronox. Okay, I'm not doing an advertisement for them, but I like to use their product. This is Neuronox vial. Botox comes in a vial like this. For unexperienced eye, you may think that the vial is empty, but if you looked closer, you will find a white halo at the bottom of the vial. Actually, you cannot find a white halo here because I already used this vial, so it's empty. But if it is like a new vial, you are gonna bring the vial and you'll have a white halo at the bottom of the vial. This is how you buy your neurotoxic proteins. Once you bring the vial, you do a reconstitution process with a saline. If it is a 100 unit vial, you are gonna reconstitute it with a volume of saline. I prefer to use a 2 ml saline. If it is 50 unit, I may use a 1 ml. If it is 200, I may use more. It depends actually what you are trying to do. If you are using a less volume of saline, then you are gonna have a concentrated solution. If you are using a high volume of saline, then you're gonna have a diluted solution with less potency and a high potential to spread. So actually it depends on what you're trying to, when I do the hands, I may use a high volume of saline because I want it to be diluted. Or when you do a meso Botox or baby Botox, you can do the same concept. So the neurotoxic protein, it is the scientific name, but the commercial name, we have a brand called Botox, we have Dysport, we have Xeomin, and etc. It comes at a vial that looks like this. In the new vial, you are gonna find a white halo at the bottom of the vial. Where you do a reconstitution with saline, then you have a solution that you can easily withdraw with the insulin syringe and inject it in the patient face. So then, oh, oops, I missed something. This vial, those are the powder form Botox. Nowadays, we can find a liquid form of Botox, such as Inotox and Pocotour. They come as a vial, which is already liquid. You don't have to do the reconstitution. You don't have to add saline for it. When you bring the vial, you should put it in the freezer. Then after you do the reconstitution process, you should put it in the refrigerator. It should be used within the first 4 hours, and it can be used up to 1 week. After that, it's gonna lose its potency, so I don't recommend to use the vial after 1 week. So what are the uses of neurotoxic protein? Typically everywhere. So we can do it in the forehead, because when people elevate their eyebrows, we can see like forehead wrinkles. We can inject Botox in it. We can inject Botox at the glabella. When we have a frowning lines that appear during doing frowning, we can inject it around the eyes. If we have wrinkles around the lateral corner of the eye, where we call it crow's feet, we can inject it along the lateral side of the nose, at the bunny lines. We can inject it at the elevator muscles of the upper lip to drop down the upper lip. When the case have a gummy smile, for instance, some people who have, especially females, and I guess you see a lot of gummy smile in India, because mostly your patients, you have to treat the periorbital area and the perioral area. When they have a gummy smile, due hypercontractility of the upper muscles of the upper lip, you have the muscles of the upper lip that elevate too much during smiling. Injecting a couple of Botox at the elevator muscles of the lip will actually help the patient to prevent excessive gum showing. And I think doing Botox is something fantastic, because nowadays a lot of patients would refuse the option to do a gingivectomy or an aesthetic crown lengthening, or to do a leaf forward and anterior maxillary osteotomy. So giving them an option that is less minimally invasive than surgery is always a patient preference. So we can inject at the gummy smile, as I said. We can do it at the smoker's line, which is the orbicularis oris muscle, along the skin border of the lip. We can do it at the mentalis muscle. We can do it at the DAO, the depressor angulus oris, which drops down the corner of the mouth and give a sad look. We can inject it at the masseter muscle, at the temporalis muscle, and we can actually use it in a lot of areas. As I said, it comes as a vial with a white powder. You do the reconstitution with the saline, then you have a solution where you can withdraw it with an insulin syringe and inject it all over the face. So the question is, I told you what is Botox, or what's neurotoxin, how it works, and where we can inject it. But as far as the perioral area, If we are gonna inject it at the gummy smile, we are gonna pick up a point which is 1 centimeter from the ala of the nose and 3 centimeter from the corner of the mouth. So I'm gonna make the patient like smile like this. Then I'm gonna mark Yonsei point, which is 1 centimeter from the ala of the nose. I'm gonna take like 1 centimeter from here. This is my point of injection for Botox for gummy smile. If the case have an anterior gummy smile, which means when it smiles like this, you get to see the anterior teeth along with their gingiva. But if the case have a mixed gummy smile, where you have an anterior and posterior teeth show along with their periodontium, along with the gingiva, you are gonna inject at Yonsei point, and you are gonna also give at other 2 points across the nasolabial fold. 1 point is actually at the deepest point of contraction of the nasolabial fold, like this, here, and the other point is midway between Yonsei and this point. The dosage will actually, a lot of clinicians, each clinician have his own dose. It's always better to inject a smaller dose than to increase the dose after 1 week. My own protocol that I give a 1 unit of Botox to each 1 millimeter gingival display. So if the patient have a 4 millimeter gingival display, I'm gonna give a 4 unit of Botox here and 4 unit of Botox here. And if you have a mixed gummy smile, I'm gonna give like a 4 unit, and I'm gonna give half the dose, 2 and 2, on the nasolabial fold. If you are to inject Botox at the mentalis muscle, actually depend on the pattern of wrinkles, but generally speaking, we are gonna inject it like a couple of units here and a couple of units here. If you are to inject in the DAO, depressor angulus oris, we're gonna let the patient do like this and mark the DAO. I guess I look funny when I do this, but I'm just trying to illustrate. We are gonna mark it, and we're gonna give like a couple of units here and a couple of units here. If you are to inject the masseter muscle, you are gonna draw a line along the inferior border of the mandible and another line from the lobule of the ear to the corner of the mouth. You are gonna make the patient clench on his teeth. You are gonna identify the muscle, and you are gonna give at a single point or at a 3 point, depending on on the degree of muscle hypertrophy, if it's male or female, and the severity of the condition. So this is so far for the neurotoxic protein. I just want to say about something. There is also this term of mesopotox. Mesopotox, it's the neurotoxic protein, but it's like excessively diluted by saline, so it's gonna be like, it just is gonna work to block the excessive sebum production, secretion, and it's gonna decrease the sweating of the T area and the face, close the open pores, eliminate fine wrinkles. So this is the term of mesopotox. Now we finished talking about neurotoxins. One last thing, whom should I not be injecting with neurotoxin? Typically patients who have a problem in their nervous system, who have a Parkinsonism or Eaton-Lambert syndrome, you are going to be afraid to do a neurotoxic for them, because you never know how much of the nerves is going to respond to the Botox. And patients with a protein allergy, such as the egg protein or the cow protein. But again, most of the newly synthesized or the newly produced neurotoxic proteins in the market do have a lower protein load, so there is a minimal chance of having an allergy to a neurotoxic protein. Xeomin, it is the purest form. Whenever there is any possibility of allergy or something, you are gonna just give him Xeomin. It's gonna be much more safe. Now we are gonna speak about filler. We spoke about Botox, and we said that it acts on dynamic wrinkles that appear to muscle movement, where you're gonna inject it to relax the muscle and eliminate the wrinkles. You are gonna inject it also at the sweat gland at the hands or the sole of the feet or underarms, and you are gonna inject it in areas where there is excessive salivary secretion, such as the parotid and submandibular. The filler, on the other hand, it is a filler product, so it volumize and fill static wrinkles. So when we are gonna do like a comparison between Botox and filler, Botox act on dynamic wrinkles, Filler, on the other hand, works on static wrinkles. So the filler, it actually may be made, okay, so this is a syringe of filler, okay? Actually, it's an old one. It's a Juvederm Ultra 2, but still. This is a syringe of filler. It comes as a syringe already pre-packed with a filler in 1 ml syringe where you inject it to your patient face. What is the filler made of? It can be made of a different product. It can be made of collagen. It can be made of polylactic acid, such as polymers. It can be made of calcium hydroxyapatite. But what is the most safest filler product to use, and the most forgiving product, is the filler based or made of hyaluronic acid. So whenever you are new beginner or new practitioner and you want to do a filler injections to your patient, always seek a filler that is made of hyaluronic acid. Don't try to rush and go on for hydroxyapatite or polymers, because those products cannot be reverted or cannot be removed easily, and they are not that much forgiving. So nowadays most of the filler that we use are actually made of hyaluronic acid. It comes as a syringe, as I told you, a 1 ml syringe, where you inject it at areas where or plump the face. We can inject it along the nasolabial fold, along the marionette line. You can inject it at the lip to give a lip augmentation, inject it at the cheek to give a cheek augmentation, inject it at the tear trough area. You can also inject it at the eyebrow to give it a little bit of a lift. You can inject it at the glabella or forehead if you do have a concavity or a static wrinkle, but those are not areas to begin with as a beginner because it have a high risk of vascular complication. You can do a non-surgical rhinoplasty with the filler product. You can do the chin. You can also do the angle of the mandible and the jawline, something called texas. You can do a lot of. You can inject also the temple in patients that have a B, like a B-nutter shaped face. But what I actually want to say that whenever you start with the filler injections, try to use it to inject it in areas which is more forgiving. Do not go for the nose and glabella as a beginner in practicing facial aesthetics. As I said, the difference between Botox and filler. Botox is a neurotoxic protein working on dynamic wrinkles. Filler is a product that is made of hyaluronic acid. It can be made of a lot of products, but we're going to talk about we're going to just focus on the hyaluronic acid based product right now. And it works on static wrinkles. So dynamic wrinkles, wrinkles due to motion like this, Botox. Wrinkles during a static is filler. But to be 100% scientifically precise, filler can be used in areas with dynamic wrinkles by utilizing the concept of myomodulation, where you can inject the filler superficial to the muscle to block its action or to minimize its action by creating a mechanical obstacle, or you can inject it deep to the muscle or below the muscle to give a leverage and enhance its action. But this whole myomodulation concept is like a pretty twisted topic, so we can discuss it in other webinar, but I'm just trying to let you know that Botox on dynamic wrinkles, filler on static wrinkles, but sometimes you can use filler on areas where there is a motion in this area. So how can we inject the filler product? We can do a linear threading. Okay, there is no needle actually for this syringe because I removed it, but I can show you. We are if I'm gonna do the nasolabial fold, I'm gonna enter with my needle and I'm gonna inject while I'm withdrawing the syringe. This is called a retrograde linear threading technique. If I'm injecting while entering my needle and my syringe, this is called an antrograde linear threading technique. If I'm injecting at a couple of points here, I'm doing a deposit here, and deposit here, this is called a serial puncture. If I'm gonna enter with my needle and place a single dose in this area, we are gonna call it a bolus. If we are doing for the tear trough, for example, if I'm doing a couple of doses here, we can call it a micro aliquot or aliquot. There's also the fanning technique where I can enter here with my needle. It's preferable to be done with the cannula. I can enter at CK1 at this area and do fanning like this. Okay, so those are typically the injection techniques for the filler. As you can see, it's a syringe. We can use a needle or we can use a cannula, a micro cannula. It depends actually on the area where you are injecting. A cannula are much more safer. They have a less risk of having a vascular occlusion. So whenever possible, it's good to use cannula, but sometimes you do use the needles. I mean, when we do a lip filler injection, I want to give this prominency for the philtrum columns and the cupid bow in this area. You will need to enter with the needle. As I told you before, at the first of this webinar, hyaluronic acid is much better product to be used because it's more forgiving. It can actually be reverted. If the patient didn't like the results or there is any lumps and bumps or any complication that may happen, you may inject hyaluronidase or Hyalase in the market, Hyalanex. This product is gonna dissolve your hyaluronic acid filler that you injected, so it's a more forgiving product. How long does the filler product last? Typically from 6 to 8 months. It may last up to 1 year in the nose, and it actually differs according to a type of area and the plane of injection and the type of filler that you used. Botox, on the other hand, lasts from 4 to 6 months, but it may last less depending on also in the area. There are some things that may make filler last longer, just such as taking care of your skin, drinking a lot of water, avoiding heavy exercise and such things. And it's like a patient variant. Some patients tend to have those products last longer than other patients, so you can never know. But it depends on actually the area we are injecting. Usually Botox and filler doesn't last that much longer the lips because you use it all the time, so the material then tend to be like dissolved very quickly. While we can use filler in the nose, it can last up to 1 year, so it depends on the area we are injecting. If anyone do have a question, please ask me, because I guess I am finished. Okay, we have a question from Dr. Asim Alam. What is the benefit of each technique or the situation to use each one? This is a good question, actually. What is the benefit of each technique? Let's say that the technique depends a lot differs according to a lot of factors. First of all, the clinician skills. Some people prefer to use such a technique other than other technique. Also depend on the area. If you are doing a lip filler, for example, it's not that much easy to do a fanning. So probably are gonna like enter with a linear threading in a retrograde or anterograde technique. However, studies have showed that anterograde techniques show a lesser degree of hematoma and bruising rather than the retrograde. So like we probably are gonna do like a linear threading in the lips. We can do it along the nasolabial fold. It doesn't make sense to do a bolus in the nasolabial fold. You're not gonna enter with your syringe and leave like a whole deposit in here. So it's gonna be a linear threading. So actually it depends according to the area. If I'm doing the tear trough area, I may place like a bolus or a micro aliquot as a soothe, and I may go on a linear threading technique. So it depends. In the mentalis, in the chin area, Dr. Asim, I can may place a bolus also, and I may go in this area with a linear threading technique. So it depends on the area. Dr. Abhishek Banerjee is asking, should we give Botox for frontalis along with the bella? This is a good question. Look, also this is like out of the scope of our webinar, but I'm gonna answer you. We have like an elevator muscles for the eyebrow and a depressor muscle for the eyebrow. The frontalis muscle is like it elevates the eyebrow like this, and the depressor muscles, which are the procerus, corrugator, and depressor supercelli, it depress the eyebrow like this. So if you gave the frontalis alone and not injecting the glabellar region, you will have the depressor muscles working like a predominantly. So we will have the eyebrow ptosis like this. You blocked the elevators and the depressors are gonna work more. And the opposite. If you injected the depressors and you left the frontalis, it's gonna be like hyperactive and the eyebrows are gonna be too much elevated, giving a weird freaky look. So whenever you do a frontalis injection, you should be also doing a glabellar injection. If the patient doesn't want a frozen look or like a fully paralyzed look, you can always go with a microtox or a baby Botox technique. Sir, can you teach what are the danger zones? Okay, this is actually a pretty question. question. There are a lot of danger zones. We are going to speak like about the filler for instance. If you are injecting in the glabellar region, the blood vessels may have a high chance of getting a vascular occlusion. So you don't want to do a glabellar injection as a beginner. You can use it with a cannula, and if you are gonna do it with a needle, you should go deep to the bone and always do an aspiration, but I prefer to use cannula. So the glabellar region have a high risk for vascular complication. Also the nose have the same complication. Typically the nose and the glabella are the high areas prominent to have a vascular complications. We should also take care of the facial artery that is at the anterior inferior angle of the masseter. It like goes up there 2 centimeters from the corner of the mouth, then it like gives the superior and inferior labial artery. It continues and ends and goes along the lateral side of the nose and ends at an angular artery. We should take care of the infraorbital artery, and we should take care of the supratrochlear and the supraorbital artery. Those are mainly the main vessels that we should take care of. And of course, yeah, the temple, the superficial temporal artery, you should take care of it. Look, whenever possible, use the cannula unless you have to use the needle. So always I choose to go the cannula, and I like to choose the 22 gauge needle because 22 gauge cannula, because I believe 27 gauge cannula acts like a needle. So I prefer to use cannula whenever I'm in an area of a high risk of vascular occlusion, and you should be fully aware of the anatomy before doing any injectables in the face, because you don't want your repetition as a doctor, clinician, or even a nurse, if it's allowed for in your country for nurses to practice facial aesthetics, to lose the repetition by doing a catastrophic intervention for their patients. Does anyone have any more questions? Thank you for pressing the. Give me more hearts, people. Okay. Does anyone else have any more questions about what we have spoke right now? Okay, you are welcome, Dr. Abhishek Banerjee. Actually, I finished my topic, but this was only a teaspoon of the information that I have. I would be very delighted if we can do another webinar. If Dr. Abhishek Banerjee would like to invite me all over again, it will really please me to do it all over again. I hope that you find this webinar useful. Please go to visit my Facebook page. I do a lot of webinars. You are gonna find the video section previous webinars I did with the beautiful guests. Actually, I did an interview with a dermatologist from India, Dr. Shaitra Anand, and I'm intending to do a lot of webinars pretty soon, hopefully. I hope you find this webinar useful. I would like also to thank again and again Dr. Abhishek Banerjee for giving me this chance to share my passion all over the globe. I have never been to India, but I would love to come when all this COVID crisis ends up soon. Thank you for your time, and be safe, injectors. Study anatomy well, and always do your work with passion. And I hope that this webinar was instructive and educational for you. Thank you so much, Ray of Hope and Care Foundation. Best of luck in everything that you are doing. I highly respect what you are doing across the states of India. Thank you so much, Dr. Abhishek Banerjee. How can I say like good evening in India? It was thank you. Okay, how can I say good evening? It's how can if someone tell me how to pronounce it? To make the pronunciation. Namaskar. Did I spell it right? Namaste. Okay. Did I say it right? Okay, great. Good evening, people. Have a nice day, and I hope to see you in another webinar. Thank you so much for your time. Thank you so much, Dr. Abhishek Banerjee. Thank you so much, Ray of Hope and Care Foundation. Best of luck. Goodbye.